diseases, palliative. So the overview of this session is common trajectories of deterioration in non-malignant conditions, possible barriers to palliative care referral, reviewing the principles of palliative care approach, and illustration of specific factors relevant for common non-cancer conditions. Before we go to the next slide, can I ask, what are the non-malignant conditions that you've come across that would require palliative care in your practice so far? People can unmute themselves and speak, or put it in the chat box, please. Low backache, CKD, okay, COPD, yes. CKD, COPD. Stroke, neurological disorders, paraplegic, yes. End-stage renal disease, yes. Dementia, copulmonary. Dementia, a lot of people with dementia, yes. Right, so yeah, diabetic neuropathy, yes, that's a painful situation. As I can see that you're quite familiar with a lot of conditions, including heart failure. Okay, next slide, please, Priya. So the patients with non-cancer life-limiting illnesses have comparable symptom burden and care needs to patients with cancer. This has been actually proven time and again. You know, a lot of people who actually conduct studies to look at palliative care needs in non-cancer patients, they come up with this statistics saying that it is as equal to or even more than the symptom burden that you find in cancer patients. And the classic trajectory of chronic non-malignant conditions is one of progressive but variable clinical and functional decline, marked by exacerbations and recoveries, and eventually a deterioration that results in death. You'll understand this in the next slide. Next slide, please. So you can see the trajectory wherein the red line indicates the cancer trajectory. So you're diagnosed with cancer, and sometimes it is a kind of a late stage or fourth stage in which there would be a rapid deterioration. But if it's in the second or third stage, you kind of carry on and go forward without much of a problem, except chemo side effects or radiation side effects, etc., with some amount of pain where we can intervene. But at a certain point, it kind of deteriorates drastically. The performance status of these patients deteriorate drastically. But if you look at the blue line, which is organ failure trajectory, which is similar to COPD, end-stage COPD, CKD, heart failure, etc., you have a decline, and then you have a sudden dip where you think the patient is not going to recover, especially in COPD patients. You find them frequently admitted in ICUs. They are supported with NIV and sometimes with a ventilator. And you feel that the patient is not going to come back, but they do recover. And they come back and move out of ICU. Then they go on for some time. Again, they're admitted. So there is a dip, and then they climb up. And there's a dip, there's a climb up. So it's very unpredictable as far as organ failure and non-malignant diseases are concerned. And the last line, which is green in color, is dementia trajectory. So you mean to say that third stage dementia, fourth stage dementia, their quality of life is basically very low. And from there is deterioration with ups and downs, which are small. But since their quality of life is very low, it is very difficult for them to pick up and move to a better place. So what we need to remember is cancer trajectory, more or less we can predict, but in non-malignant, non-cancer patients, it's very, very difficult to predict. You might think, okay, this patient is going to collapse, this patient is going to die. For example, I don't know how many of you have seen HIV patients, and they come up with a cryptococcus infection, and they have meningeal disease, they have CMV virus, and brain infestation and things like that, and feel that they're going to die because they're so sick. But with medications like amphotericin and antiviral medications, they come up and their life, it can be regained back, and by giving them regular ART and things like that. So it's very, very unpredictable. How to take a decision when they are actually going into end of life is a big question. So next slide, please. So what are the barriers to palliative care? All of us know that even with cancer patients hesitate to come to palliative care, thinking that, okay, that's a last stage in life and that's it, we are not going to come off this. So there are a lot of barriers, but even, it is more so in non-malignant cases. So what are the barriers? Let's have a look. Next. Clinician, patient, or family discomfort in discussing palliative care. The patients or the clinicians themselves don't want to initiate palliative care, thinking that they are actually, doing a disservice to the patient, instilling fear in them and things like that. So first of all, the clinicians need to understand that is not the case. Then some of them have previous poor experience with palliative care. Some, why? Because they are kind of referred in the last stage of life. And then the patient suddenly dies. So sometimes we see patients in palliative care who are there with us only for 24 hours or for a few hours. That is not the right time to refer to palliative care. Then uncertainty regarding the role of palliative care. People do not know what exactly we do from both patients and clinician side. Next slide, the next point. So cultural considerations around discussing death and dying. And a lot of people, they're not very comfortable, especially in the Indian scenario, to talk openly about death and dying. What do we do when that time comes? So how do we cope with that? So, and we have this big thing about collusion, that the relatives, they do not want us to speak to the patients. And they, because they think they're protecting the patients from actually speaking about, preventing us from speaking about the diagnosis, the prognosis, and death and dying. So when the time comes, people really do not know what is to be done and what is to be expected and things like that. There is a slight change, of course, over the years, because we've been into the field of palliative medicine for more than 2 decades now. So we can see that slight change where people are aware of, say, for example, cancer or the other disease, and they say that they know that it is bad, but they don't know that they've reached the tether, the end stage. So that's still elusive, So cultural considerations very important. Unclear triggers for referral, limited clinician time. These kind of things. We sometimes receive a referral and we do not know what the referral is for. Is it for pain? Is it for talking to the family members? Is it for making an advanced care plan? Or is it for talking about what are the goals, the care goals of this patient? So sometimes the triggers are very unclear, and sometimes we do not have time to speak to every patient or the relative, because each patient takes probably more than an hour or so. Okay, next. And fear of taking away hope. So people, their consultants themselves do not refer to us, thinking that the patients will think that they've given up. There's nothing else that they can do. So that's what happens most of the time. Next. So lack of recognition of the impact of symptoms on quality of life, because people say, end-stage renal disease, they are going through dialysis, and suddenly they realize, okay, this patient's blood pressure is not good enough for us to even do ultrafiltration. Forget about dialysis. And they do not know what to do with that, how to convey that news to them, or what is to be expected in the next 2 to 3 weeks, because they're not able to undergo dialysis. Because mostly patients, they can kind of carry themselves on for weeks together, and if not for more than a month. So they might have pain, they might have toxicity, they might have agitation with all the accumulated toxins in their body. And the impact of symptoms, sometimes the consultants fail to consider. And the patient fear of abandonment by the usual clinician. This is very, very relevant, because they would say, okay, my clinician said this is what is to be done in case of pain. They told us to take as and when required. So we need to do a lot of education and make them unlearn what they've learned, and then allow them to relearn. So that very often it happens. A focus on the disease rather than the needs of the patient. This is very common, as you can see in your practice. Limitations in the availability of palliative care services, especially in more rural and remote areas. So then we do not, get those referrals here. Next slide, please. the timing of palliative care. This is a $1 million question. When do we actually refer for palliative care? Okay. Now, it is picking up in cancer patients, but it's not there yet in non-cancer patients. I can't say that it is kind of uniform all over India for cancer patients, but there is a general trend that the cancer specialists are recognizing the importance of palliative care, and they are making reference. But in the case of non-cancer patients, we have not reached that level yet. So what are the clinical factors which would indicate, okay, that it's time for referral to palliative care? Deteriorating functional capacity with increasing care needs. People become more bedridden, they're not able to breathe. They have severe exertional breathlessness in case of COPD or heart failure. And they need more help with their daily chores. Recurrent or unplanned hospital admissions, sudden deterioration, and they get quickly admitted in hospitals and they get discharged and come back again, that sort of thing. And refractory symptoms despite optimal management. You could see this commonly with cardiac failure patients, wherein they have IV Lasix in the rate of 200 and 250 milligrams going in, and still having breathlessness. And in such patients, we have noticed that even a small dose of morphine can make a huge difference. Next slide, please. So what are the tools which would indicate, okay, it's time for referral to palliative care? As we all know, in cancer patients, surprise question, which works in non-cancer patients as well. So what do they do? Which asks whether it would be a surprise if the person died in the next specified time period. Now, what people say regarding this tool, a surprise question is, are you surprised? Will you be surprised if the patient is going to die in the next 1 year? That's what this tool says. But it's so difficult to predict what is going to happen, in the next 1 year or even the next week or so. And generally we can say, okay, looking at this patient's performance status, looking at the stage of the disease and their physique and their functional capacity, we would say, but looking at the progress of the disease, would you be surprised if the patient is going to be alive at the end of 1 year? If the answer is yes, then it's time to actually talk about palliative care. And the other very important tool is palliative care indicators tool SPICT. I would really advise you to go and have a look at this. Please note this name, SPICT, which includes disease-specific markers of deterioration. It has all the diseases in it, and it has, numbered it under each disease. What are the things that you need to look for? Please do have a look at it. SPICT is a name of the tool. Next slide, please. So the main focus for PC non-malignant diseases, what should it be? Of course, it should be first symptom management. Next point. Next point, please. Symptom management, attention to expectations and fears, and advanced care planning, and can occur concurrently with treatments that we need to know that they are directed at optimizing health and preventing exacerbations. Next slide, please. So let's come to the first thing. So this session, I'm going to just talk about different diseases and what are the main things in it. And at the end of it, you can all ask questions and what are your doubts regarding each disease. And we will have an interactive session. That's what I've planned for the session. So COPD, optimization of disease-specific management, including appropriate inhaler therapies. For example, we now have a patient with ALL. This is just stating as an example. She's an 18-year-old kid with ALL, and she's receiving buprenorphine 0.2 milligrams sublingual for her pain, which is abdominal and leg pain, because the marrow is getting suppressed and she has severe bone pain as well. Apart from other medications, buprenorphine works very well for her. And then we found out that she's, in spite of giving buprenorphine, she's still complaining of pain. And then we found out that she's not taking at the optimal time. She's skipping medications, and whenever she would require, she would take it. So it's very important as healthcare professionals to ensure that these people are actually taking in the puff and their inhaler technique is good. And if not, are they taking through a spacer? Many of them do not have the capacity to actually inhale. So it's better to take through the spacer. You need to be very, very clear on this. So first of all, optimize all the medications that these people have. And attention to symptom management, definitely cough. They're not able to lie down when they have cough pulmonale. Apart from the other medications like bronchodilators and other things, they would probably require Lasix as well if they have cough pulmonale. Then, of course, they need support for smoking cessation, action plans for the management of exacerbations. What do we do if we have exacerbations? Are you taking extra puffs of this? Are you taking some medications like, say, Vicelon tablet? We do not know. So we need to have a plan for them. Consideration of routine vaccinations in such people, like the flu jabs, etc., which is very prevalent in Western countries, and attention to comorbid conditions like depression and anxiety. So every time the patient gets admitted, they feel that their freedom is being robbed and they're not able to decide for themselves. They're not able to do things on their own. So these people definitely go into depression and anxiety, and their dyspnea in the exacerbation is added on by these kind of symptoms like depression and anxiety. And definitely do try pulmonary rehab. How many of you have pulmonary rehab in your hospitals? I do not know, but a lot of hospitals have pulmonary rehab nowadays. So please do make a referral to all these people. Next slide, please. Next slide. So some evidence that low dose morphine can be safely and effectively used to treat refractory breathlessness in patients with severe COPD. So we look at referrals from patients with severe COPD, and they miraculously improve. And sometimes we even do start a small amount of morphine infusion to ensure that they get it around the clock. It might be just 3 milligrams of morphine IV round the clock, or quarter tablet of morphine, quarter tablet once 3 times a day. One tablet three times a day, in the sense like 10 milligram tablets, quarter tablets 2.5 milligram, oral 3 times a day is what we start with if the patient is opioid naive, and it produces a lot of comfort to the patient. As you would know, many of you would know this. And when providing opioids for breathlessness, consideration should be given. Of course, adverse effects should be noticed. And there's a lack of evidence for the use of benzodiazepines for the relief of breathlessness in COPD. It's a common practice that we give lorazepam or clonazepam in such patients, but there's no actual scientific proof. But you still can use it if everything else has failed. You've given morphine, you've given to the extent to which they can tolerate. That means they're not too drowsy, and then you're not suppressing the respiratory center, and they're adding on to their dyspnea. If that's the case, then you can definitely try benzodiazepines. And if we feel that they have anxiety, we can try lorazepam, 1 milligram or 0.5 milligram sublingual. In Western countries, we have sublingual preparation already, but in India, we use the oral tablet as sublingual medication. There's also a lack of evidence for the use of oxygen for relief of breathlessness in patients who are not hypoxic, but basically we keep it for placebo. The patient feels comfortable, the relatives feel comfortable. Otherwise, they feel, oh, we didn't even give oxygen to these patients, even though when they are very breathless. Next slide, please. So end-stage renal disease, patients who are treated conservatively for ESRF and those considering cessation of dialysis are likely to benefit from a palliative approach, as I said earlier. So what are the common symptoms in end-stage renal failure? So fatigue, breathlessness, pain, nausea, poor appetite, fluid overload, and itch. Of course, breathlessness contributed by fluid overload, and itch because of uremia. And in order to control the itch, because of uremia and the skin deficit, ondansetron would be a good drug to control that itch. And of course, you will have agitation and hallucination and encephalopathic feature with uremia, and you can control it with haloperidol. So there are a lot of things that you would do normally with any patient, and that you can still repeat it in these patients. All you need to remember is patient is non-dialyzable. The amount of medications that we give should be very small, very, very small, so that the patient benefits from it via symptom management. And you need to have planned and unhurried discussions with the bystanders, maybe with the patients when they are actually, gone through this repeated dialysis and they have sort of given up. We can sit down and have a chat with these group of patients and their relatives. Next slide, please. What about cardiac failure? So diverse syndrome with variable patient trajectories. So it's very difficult to predict, very, very difficult to predict. And symptom burden in advanced cancer failure is again comparable to that of advanced cancer. Advanced cardiac failure is comparable to advanced cancer and includes breathlessness, fatigue, nausea, and constipation. In cardiac failure, we need to understand that there is left-sided failure, there is right-sided failure, there is CCF that happens. And CCF, you can have hepatitis and hepatic congestion, and you can have ascites due to cardiac failure. So everything contributes to the breathlessness. So you need to find out whether there are any correctable things. And of course, diuretics is the main drug of choice. And we need to make sure that optimization of medications are there, and we can give up morphine shot for these patients. So low dose opioids, as I mentioned, may be considered, and advanced care planning and deactivation of defibrillators. I think this is something which people hesitate to talk about, and they don't want to deactivate it because they want the defibrillator to act. How many of our patients are on defibrillators? I'm not too sure, but they're very common in other countries. So we do have pacemakers in our patients, and we do have defibrillators. So we need to be aware that this can be done. We can have an advanced care planning, and we can deactivate the defibrillator. Next slide, please. So what about neurological conditions? A lot of you mentioned about dementia and diabetic neuropathy and things like that, which are purely pain conditions. But neurological conditions, progressive and life-limiting diseases such as motor neuron disease, Parkinson's disease, and dementia. Okay, and motor neuron disease, they're not even at a certain stage, they're not even able to express what they want, what they would like for us to do, and things like that. There are a lot of equipments that are available. By just looking at a computer screen, you can pick up letters, and you can write even without even moving one finger. So there are a lot of equipments that is available, which is costly, and it is available for patients who can afford, or in institutions sometimes they can be made available, but it's not so common in our country. So motor neuron disease, Parkinson's disease, and dementia. These people have a lot of course, mobility impairment, constipation, swallowing difficulty, etc. And in dementia patients, they forget to eat, and how do you make them eat? Should we put in a rice tube? What is the performance status of this patient? Who is looking after them? What can be done to feed them, and things like that? So it is an extremely tough decision to take whether to put in a rice tube, NG feed tube especially in dementia patients or not, because sometimes the patients are so adamant that they refuse to eat, and when you put in an NG tube, they immediately pull it out. So it's a catch-22 situation where palliative care physicians will or professionals will find themselves in. Extremely difficult to actually decide which way to go. And symptoms are individual and complex, and the involvement of a multidisciplinary team is essential, very, very important. And swallowing and respiratory changes in decubitus ulcers happen because multiple sclerosis patient, motor neuron disease, they're bedridden, they need to be turned every 1 hour, 2 hours, depending on their physique. And we need to prevent decubitus ulcers from happening, or pressure sores from happening. Next slide, please. HIV/AIDS, I don't know how many of you see HIV/AIDS patients commonly, but they have absolutely different pain syndromes, a lot of pain in these patients. They have a lot of psychosocial issues, they have a lot of spiritual issues, and rehabilitation issues. And we need to actually, explore these things, and you come across certain things that you can't even imagine, and the pain that these people go through. Next slide, please. So the pain syndromes in HIV, you commonly have abdominal pain. You have cryptosporidium with diarrhea. You can have lymphomas in these patients. You have lactic acidosis with these ART medications. You can have pancreatitis with ART medications. So lots and lots of causes for abdominal pain. You can have peripheral neuropathy with HIV itself, the virus itself, and also medicines like stavudine, which is a common component of ART medications. You have oropharyngeal pain, of course, aphthous ulcers, dryness of your mouth. You have oral thrush commonly in these patients. Headache because of, like I said earlier, cryptococcus and CMV virus, etc. You have post-operative neuralgia, which is commonly seen in such patients because of immunosuppression. They have post-operative neuralgia, and musculoskeletal pain goes without saying. You have proximal myopathy. They find it extremely difficult to get up from where they have sat, and they have cachexia and anorexia syndrome. If the virus multiplies, when the CD4 count falls and the virus multiplies, they have cachexia and anorexia syndrome. And what they commonly find in these, what you commonly find in these patients is they have difficulty in sleeping. Okay, insomnia, and I think that because of the inflammatory markers, which is very high, looking at the cachexia and anorexia syndrome, you have inflammatory markers very high. This happens in cancer patients too, but more than cancer patients, when CD4 count is low and the viral load is very high in such patients, they find it extremely difficult to sleep, and you struggle to make them sleep. You give them clonazepam, you give them solpatinib, you give them all sorts of things. You put them on antidepressant like mirtazapine, which is sleep inducing, and they find it difficult to sleep. But ART works better in such situations, and you need to make them compliant with ART. But ART, it's very difficult to start immediately. So sometimes they have, fallen out of the ART program, and then you can't suddenly bring a patient and start them immediately. So you have to kind of, take it slow. Otherwise, they have this immune flare-up, and they end up with all sorts of things, and which can even lead to death. So you need to be extremely careful. Next slide, please. End-stage liver disease. Patients with compensated cirrhosis have a median survival that may extend beyond 12 years. With compensated, please listen carefully, it is compensated cirrhosis. And you normally come across referrals when we get referrals, it is decompensated, chronic liver disease. Next point, please. So advanced care planning, next point, please. So formal advanced care planning processes assist patients and families and clinicians to discuss and document preferences for future care. How much of this works in our kind of scenario is questionable, because we don't have a legal person coming in and appointing a surrogate and say that if I'm incapacitated, this is my representative who will take the decision. I'm giving him the full rights to do that decision. Sometimes it is very difficult, and sometimes it's very difficult to see what will happen 2 years down the line. What are the kind of symptoms that I will have, and at that point in time, what do I want? So that might change. So it's extremely difficult to have an advanced care planning, but you can have a general advanced care planning saying that if some of the interventions are futile, I don't want to go on a ventilator. So maybe that you can have. Next point, please. So focusing on patient values, preferences, and cultural and spiritual needs can help frame these discussions. Okay, so some of them will want their priests or or their pujaris or who were close to them in the spiritual realm or religious realm, if I may say so, to be called and discussed and things like that. So of course, you can give them for them the freedom to do that, and it would help them probably to identify a substitute medical treatment decision maker, which is useful for future illnesses and episodes. This is in conjunction with a discussion with your family, your background, and this is what we do as and when it is required and things like that. Next slide, please. So patients may have clear preferences about the suitability of interventions such as antibiotics, non-invasive ventilation, and more intensive levels of care. So people would say, okay, I wouldn't mind antibiotics. I wouldn't mind NIV. That means you can keep a BiPAP and probably look after them in the ward. But I would say, okay, then they would say, I don't want to go to the ICU or I don't want to be put on a ventilator. So people have different choices. So patients with severe progressive disease, the treating team should determine which interventions are medically appropriate. So even though we have the capacity or the legality to actually decide this treatment is futile, I'm not going to put the patient on a ventilator, still the patient's relatives is what we do, who we discuss with is what I meant to say. We discuss with their relatives because we generally don't get to talk to the patients about their, end of life care, if I may say. So very rarely we will have patients who are really with it and understand what they're going through and who are bold enough to discuss about their end of life care plan. So it's mostly the relatives that we healthcare professionals discuss these things with. So it is our prerogative to decide which is suitable or not, but we always take a joint decision. We sort of, talk to the relatives and convince them that this is futile and you wouldn't want to go that way. Most of the patients' relatives agree, but some of them do not agree, and it's very difficult to sort of, brush them aside and say this is what we're going to do. Advanced care planning can help the patient, family, and treating doctor provide the most appropriate care in the most appropriate venue. That means, okay, no, I don't want to come to the hospital, like I want to be at home, etc., etc. Next slide. So, advanced care planning and end of life in such patients management are similar for patients with malignant and non-malignant conditions and include attention to physical symptoms and psychosocial needs, attention to personal care and support for families and carers. If you have not already undergone the classes on end of life care, I'm sure you're going to do that. What are the symptoms that you commonly see during end of life and how to tackle them? So you'll be able to, learn from that. So I'm not going into the details of that. So it could be carried out in home care or inpatient admission. Sometimes, the relatives find it extremely difficult to look after patients who are really symptomatic. They need, right now we have a patient who has CS stomach and it is spread to the bones. He has severe bone pain. And since yesterday, we have given him almost 50 milligrams of IV morphine, okay? 50 milligrams of IV morphine. And now it looks like a terminal painful condition, and we are sedating him, and it's continuous infusion, which is going with all sorts of medications like nefupam, paracetamol, ketorolac, and things like that, and plus sedative things. And he's on the verge of, panic and psychosis and things like that. So we're giving him benzodiazepines and haloperidol. So these kind of patients, they can't be looked after at home, but we need inpatient admissions for such patients. Next slide, please. So the key points. People with advanced non-malignant illnesses have comparable symptom burden. So don't think that their symptoms are actually different. It's just that the underlying disease, we need to make sure that they are on optimum treatment for their underlying disease. And while symptoms are often disease specific, problems such as pain, nausea, fatigue, breathlessness, anxiety, and depression are frequent in both. Next slide, please. So there are a number of clinical factors and specific tools available to help guide decision-making regarding when to adopt a palliative approach and to refer palliative care services for people with advanced non-malignant illnesses. Like I said, please have a look at SPICT. Unfortunately, I couldn't actually present it from my desktop from my workplace because it is not allowing the ECHO platform. That's why I'm kind of presenting it from my phone. So I had it all ready, but maybe I can send it to Priya, that tool, and then you can distribute it to them. Priya, if you can do that, that'll be great. Okay, next slide.
Sure,
yeah, thank you. Next slide. Oh, sorry. The specific tools, yeah. So a range of barriers to the adoption of a palliative approach and a referral to palliative care services exist for people with advanced non-malignant illnesses. There are things that can be done, and it can help to ensure that the advanced care planning can help to ensure that most appropriate care is provided in the most appropriate venue. This is what we said last. Next slide, please. So now the floor is actually open for discussion. We've been discussing about different non-malignant diseases in the past 40 minutes or so. It's extremely difficult to go into each and discuss about what are the needs and how do you tackle them, because the symptoms are common and you can use the same kind of medications in all these patients, except, when you look at Parkinson's disease, and when Parkinson's disease patients, they have delirium and agitation and those kind of things. Please avoid haloperidol because they can, have more of EPS symptoms with them, extrapyramidal side effects in such patients. So do not prescribe haloperidol for Parkinson's, but prescribe risperidone, which is an atypical antipsychotic. The other one is a typical antipsychotic where you have more chances of having side effects with QT prolongation and EPS. But risperidone, the chances of it is less compared to haloperidol. So in Parkinson's patients, if you come across delirium, please do prescribe risperidone. 0.5 to 1 milligram to begin with. You have 1 milligram tablets. If you're not sure what dose to start, if the patient is small, petite, small build, you can have 0.5 milligram to start with, and then build. Okay. Now the floor is open for discussion. You can either unmute yourself and talk, or you can post questions on the chat box. And if you don't have questions, that is also fine.
Thank you, ma'am, for taking us along, giving us a small picture of what it means to take palliative care along in non-cancer illnesses. We already have a question. Anish, sir, would you like to unmute yourself?
Yeah, sure. So I've been working in this treatment of COVID patients. So there are a lot of scenarios like post-COVID patients who come with severe fibrosis and respiratory distress. So in these patients, if we give morphine or sedation, patient can actually go into respiratory failure. Even type 2 respiratory failure is also happening in such patients. So is there an option like, and it is a new scenario actually. So I would like to get some feedback on that post-COVID scenario.
Yeah, so we do. Thank you for that question, Dr. Anish. And we do have patients who are referred to us for post-COVID breathlessness because they are they have fibrosis and other things. And they, from our experience, they do recover from this breathlessness with oral morphine. These are patients who are admitted in the ward. I'm not talking about people who are admitted in the ICU. Even in ICU, you can give it under monitor. And these patients can actually function, and they go about their daily activities. Some patient who was not even able to get up and sit up, severe breathlessness even at rest, and they did become better with morphine. Very small dose we start, maybe quarter BD, and then we build it up. So we've had experience without the patient going into type 2 respiratory failure and carbon dioxide retention. So we have had experiences, but we go very, very slowly in such patients.
Thank you.
Ma'am, we have few questions in the chat box.
Yeah.
So starting with one of them is, can we use morphine for refractory shortness of breath in cancer patients as well?
Yes, definitely, definitely. That is one of the drugs to go to, and it's not only for pain, as you would know, as you would realize now. And the reason why does morphine produce relaxation of breathing is, one is it acts centrally and it controls your respiratory rate and you feel a bit relaxed. But more than that, it's a vasodilatory thing. So when you have lung fibrosis or interstitial lung disease or cardiac failure, which puts so much pressure on the heart, it has to pump against a lot of force. When you have vasodilatory effect, the pressure, against which the heart needs to pump is low, and thereby the pressure on the pulmonary vessels become low. And that's when, you feel that breathlessness being relieved and vasodilatory and the fluid moves out. In CCU, used to find this. I've not worked in CCU off late, but long ago, we used to give IV morphine for pulmonary edema in such patients, apart from Lasix. That's a rationale behind this. So definitely you can give morphine. You can give IV morphine, a small continuous infusion, and the patients become really miraculously better. That's what we've seen. And if they can take orally, definitely oral morphine.
Thank you, ma'am. Another question is, in non-malignant diseases, for example, say in COPD, cardiac failure or renal failure, when would it be appropriate to switch from the primary care physician to a palliative care physician?
So again, that's $1 million question, like I said. But there's frequent admissions with the same kind of symptoms, and each time they get admitted, they go to ICU or an IV, and they become better they put on an IV, etc. They become better, and they get referred back. So if there's a criteria which says if you have, like, say, 4 admissions in the past 1 year, in a year you have 4 or more admissions, and I think it's time to sort of involve the palliative care team to find out, and the pulmonary rehab, because there's a lot of things that exercises and breathing techniques can do for these patients, and we kind of form a liaison between the pulmonologist and the rehab team. They have sometimes a very good pulmonary rehab team, and we don't need to actually liaison with them, the pulmonary physicians themselves. But we work along with them, and the experience is very good. They do refer to us. Sometimes it is a bit late, but there are patients who are in our care for months together, and they are on very small dose of morphine. So as a criteria, you could say 4 admissions in the past 1 year in the hospital, exacerbations of COPD or cardiac failure. Then you can approach them and say, okay, it's time that we talked about further management and end-of-life care in such patients. So can we, discuss those kind of things with the relatives? You can begin from.
Thank you, ma'am. Just as a follow-up of that question on whether morphine can be used for shortness of breath in cancer patients, Dr. Mrinalini would like to know if what is the dose which a person can be started on for shortness of breath?
Yeah, so normally, if the patient is opioid naive, for example, he or she is not receiving any sort of opioid, neither tramadol, neither buprenorphine, neither morphine, neither fentanyl, then we would start with morphine, quarter of morphine tablet. We have 10 milligram immediate release tablets here. So we would begin with looking at whether the patient is really breathless or not. We would begin with, and the renal functions, if they are okay, we would begin with quarter tablet, that is 2.5 milligrams, 3 times a day, and then we would build it up from there. But if the patient is on morphine already, okay, the patient is having pain, the pain is well under control, the patient is having breathlessness, intractable breathlessness, and the patient really needs morphine, you can add 50% more of the total dose of morphine that the patient is receiving in 24 hours. Add 50% of that dose in divided doses throughout. Suppose the patient is taking 5 milligrams every 4 hours. The patient will be, say, getting 30 milligrams in a day for pain, and you can add 15 more milligrams to this. So maybe make it 1.5 tablets if the patient is getting 1 tablet, or make it 1 tablet if the patient is getting half a tablet. And there's a lot of relief for such patients. So depending on the renal functions, and depending on whether the patient is opioid naive or not, then you can decide on the dose for these patients.
Thank you, ma'am. Dr. Gregory would like to know, from a palliative care perspective, in patients with end-stage renal failure with severe anemia, is it advisable to transfuse whole blood in these patients? Yeah.
So again, if how many times have you transfused, or how many times have you given him iron transfusion in such patients? And there is a time where you need to kind of limit yourself and say this is not going to work. It's the same in ALL and AML patients. When the platelets fall down, they would transfuse platelets. They would have received umpteen times the platelet transfusion, receive umpteen times packed blood cells. So if the patient, say for example, has a goal to achieve, it's very difficult to answer this question if the goal to achieve in the sense, the important thing is happening next week and the patient needs to be alive. And if you feel that, okay, by giving this, you're actually prolonging the life of the patient, but not the quality. So maybe for some reasons you need to do that. But if you think that is just prolonging and there's absolutely no quality in life and the patient doesn't want to do it, then you don't need to do it. But most of the time, the patients feel that they want to do these transfusions because they feel that we are giving up on them. So you need to explain to them, but we can't refuse the patients from transfusing. Maybe you can buy a little more time and then push it a little further and say, okay, now I'm going to transfuse. If this doesn't come up, maybe I can transfuse, that sort of thing. So maybe You can't transfuse frequently, but maybe we are not going to look at the bloods in the next 1 week or 10 days. Maybe we'll check the bloods. That those are the kind of negotiation skills that you need to have when you really know that this is not going to help.
Thank you, ma'am. There's an interesting question which has come up. Dr. Smita is asking, in your years of experience as a palliative care physician, have you had conflicts with treating physicians regarding the choice of drugs which can be used in patients?
The treating physicians, in the sense, the main physicians, is it?
The primary physician, yes.
The primary physicians, the choice of drugs, yeah, of course, definitely. Sometimes we just simply prescribe paracetamol, and they're like, "We've called you to prescribe paracetamol." That was my first experience around 15, 20 years ago, I would say. But with paracetamol, the patient recovered. It's like giving them round the clock. The choice of drugs, definitely, because sometimes we want to give them steroids. But we need to be careful in oncology patients when we give them steroids. Sometimes they have not undergone biopsy, and they're about to undergo a PET scan or MRI. So we need to make sure that while actually treating, we are not actually hindering any of the diagnostic procedures, because biopsy becomes very difficult if the mass becomes small. The peritumoral edema is taken away, and then the mass becomes small, and if they have to do a lymph node biopsy, so they really don't prefer. So we need to be careful when you're. So over the years, we've learned, okay, this patient is posted for this particular procedure. So are we justified in giving them this particular drug for this patient? And as far as the choice of opioids go, I don't think we've had a problem in that. But certain problems with maybe can arise with haloperidol and quetiapine, because sometimes we find oncologists prescribing quetiapine as a sleeping pill. It is not a sleeping pill, it's an antipsychotic. So just to get sleep, they prescribe quetiapine when zolpidem doesn't work. So we have found that clonazepam would be a better choice. And so sometimes we are at conflict with them. The patients are already on quetiapine, and and still they say, okay, we're not getting sleeps, and we would gently say, okay, can we stop that, and we'll add this on. But the oncologist here wouldn't come and eat our brains about it. If we have changed, we have changed. That's it. Yeah.
Thank you, ma'am. A lot of interest still persisting in shortness of breath and usage of morphine. Dr. Shabnam is asking if we want to give a continuous infusion for shortness of breath, at what dose can we start, how to titrate, and when to stop that as well?
Yeah, so like I said earlier, suppose we want to give a continuous infusion, you need to be extremely sure that the patient is not able to take oral tablets in the first place. So if you're not sure whether the patient is going to be more sedated or the kind of dose that the patient would require, because however we calculate, we cannot predict what is the dose that this patient would require. So it is always better to start a very low dose. You could say, you're going to give him, say, for example, 1 milligram IV stat dose and see what the patient has. How does the patient respond? If you don't have any oral medications, the patient is not able to take anything orally, doesn't have a RICE tube, okay, fine. So you give 1 milligram IV stat, see how the patient responds. So I'm sure like you will be taught about morphine titration for pain in Palliative. Of course, Dr. Rajgopal is our teacher and he taught us that. So I'm sure you'll all be taught about morphine titration for pain. So a dose will come where you will find, okay, the patient is becoming very sleepy, but it will start, that kind of sleepiness will last only for 4 hours. And if you want to start a dose over 24 hours, and looking at the renal factors and the severity of the problem, then you could, I would say, safely start 5 milligrams in 24 hours. We've done that and then put a small dose as SOS, say 0.5 milligrams or even 1 milligram. So 5 milligrams in the background as 24-hour infusion. This is not a hard and fast rule. You have to be your own judge, and each patient is different. So you need to, be on the safer side as well. You can't push the patient on the other side. Like Dr. Anish said, the type 2 respiratory failure should not kick in. And you cannot allow people to have carbon dioxide retention. So you need to be careful and then write the SOS dose accordingly. And if the patient is having more exacerbation.
Thank you, ma'am. There's another question from Dr. Anish. He's asking that in a non-cancer patient who is responding well to IV morphine or fentanyl, who was in the ICU, but we would like to shift him out of the ICU. Is there any restriction to shifting him to a fentanyl patch if he is responding to IV morphine? Yeah.
No, definitely not, because fentanyl patch, what we need to understand is we need to actually calculate the dose of fentanyl patch that you're planning to put the patient on, because morphine to fentanyl conversion we should be thorough with. When we are actually giving 60 milligrams of morphine in a day, that will be like 25 micrograms per hour of fentanyl patch. Okay, 60 to 90 milligrams of morphine, you can put the patient on 25 micrograms of fentanyl patch. But what we need to remember, I'm sure like this would have been taught to you earlier by somebody who had taken pain management, is that fentanyl patch, it will start working only in the next 18 to 21 hours. Okay, so for the fentanyl patch to kick in, you need to give some time. So either you continue the morphine infusion outside, or you give oral morphine if the patient can take oral morphine. But I assume that patient is not able to take oral morphine, the patient was in ICU. So you can definitely continue the morphine infusion in the ward. We commonly give morphine infusion in our wards and not in ICUs, basically. So you can put the patient on the patch, and if the patient, there's no other contraindication. And mind you, it is better in some sort of some amount of renal failure also. So fentanyl is a better choice than morphine if the patient has kidney problems and the creatinine is slightly high. Fentanyl would be a better choice.
Thank you, ma'am. If anybody else would like to ask any question, please unmute yourself or you can raise your hand. Yes, Dr. Newstar.
Yeah, good evening, ma'am. Thank you so much for that wonderful presentation, ma'am. Actually, I'm an anesthetist, and I've had very little experience in managing palliative care. But of course, in our state as well, like I'm from Meghalaya, and we have not yet developed a palliative care department, probably like what other states would have. So I was just a bit inquisitive, ma'am, in the sense like I was just curious in the sense that. Actually, in the palliative, I have always thought that probably the palliative care is the time only when we've reached a stage where there is as primary care physician we feel we cannot do anything more for curative intent for the patient, so we switch to palliative care. But I have realized during the course of discussion, like I think we have had a shift in that sense, in that palliative care can be started very early on when we saw in that palliative what we saw in the palliative care model which they have taught us in the earlier classes. But what I was just wondering, ma'am, in the sense like two primary of course you had mentioned that in the barriers in your presentation as well, like from the clinician side as well, you have barriers in the sense like we do not want to give referrals to a palliative care physician very early on in the stage of the disease as well. But what I would like to know is, in your practice, ma'am, do you get early referrals? Like, and also, what is the kind of discussion which you have with your patients when you are being called very early during probably the diagnostic process of the patient, be it cancer, be it early stage of your non-malignant cases? So do other primary care physician involve you, ma'am, very early on during the course of the disease? And what kind of discussion do you have with the patients or patient's relative very early on the disease? Because I think probably the patient and the patient relative would like to know more about the diagnostics, the treatment options, and they would not like to talk much about, what are your wishes that you'd like to do. So, I mean, how do you make that switch, ma'am? I was just curious.
Exactly.
It's a handful of
Yeah.
Of query.
Yeah, thank you, Dr. Newstar. I think it's a very, very important question. So here at Amrita, we have kind of put up a system wherein any patient admitted under oncology and hematology in the past 24 hours, our team will visit once in the ward. Okay, so they don't refer these patients to our OPD regularly. OPD patients, only when they have symptoms like pain or other symptoms, they do come to us in the OPD. But we've made it a point in the past couple of years that we are seeing all patients admitted in the past 24 hours under hematology and medical oncology. So the conversation that we have with them is we introduce ourselves and say we are from this team. We are working with, we are a sister team with this particular consultant. We are another team, but we have come to inquire after your wellness. So do you have any pain? Are you sleeping well? Are you eating okay? Where are you from? Who are all there to look after you? Some of them have financial problems, and then we get our medical social worker or the oncology social worker to talk to each other and help them in that kind of a thing. So the idea is, Dr. Newstar, is that every time they come for chemo, they get admitted, we go and show our face to them, right? And they understand, okay, these people are from, these people are there. They're not, you don't need to be scared of them. You don't need to be worried that what are they going to do? So when actually, so in this way, we've picked up patients that we put in our list to see every day because they do have symptoms. Some of them have severe constipation, some of them have pain, some of them have neuropathic pain, fatigue, those kind of things. So if we make an intervention, then we write in the notes. Like, for example, this is what has happened and this is what we are going to give. And we have blanket permission to write in the drug chart, whatever drugs we need. Okay. So we prescribe, that's our understanding with our oncology team. So we make a prescription and say that this is what is required for this patient. And sometimes we change their prescriptions also. That's because of the rapport and the understanding that we have with the oncology team. And those patients who are symptomatic, we see them every day. But it's so much so that patients, who come with for chemo and they see us every 2 weeks or every month or whatever the schedule is, they are like, yes, doctor, that day you had given us pain and it went away. We had those medications. Do we have to have it again? Now, that's the kind of conversation that we have at the moment. But when they require regular referrals, then they come to us and they feel comfortable is what we have seen after we started this. So you needn't directly chat with them and say, at some point, these treatment is not going to work and you're going to go deteriorate and further. No, you don't need to do that. So what is it that, keeps you going? What are you doing? Where are you coming from? What are the kind of things that you would like to do? Those kind of things you can explore. Sometimes our social worker goes back and does that. And, we have a preliminary kind of survey. But every time you see them, you remember these patients, isn't it? Every 2 weeks, you see someone, you remember them. And they also see you and they know that we are from the pain and palliative care team. And they kind of lose their fear about being referred to palliative care. So that's what we do. I can't say that it is kind of optimal that what we do, but we are on the right track is what I can say. And there's a long way to travel, Dr. Newstar. So believe me, so we are on that path, but sometime, somewhere we will reach the optimum level.
Ma'am, I think you have done it quite well with oncology and hematology team, but probably not like what you have mentioned. I think with the other departments, be it the other non-malignant illness, I think probably we've not reached that level, I believe.
We have not reached that level. The other day I had a conversation with the renal physician here. So I said, why don't you start referring these patients? Neuro, they refer patients to us because pain management is a big problem. And they have, looking after them, taking care of them, those kind of issues. So we get referrals for neuro patients. But renal patients, they would like to remain with their consultants and their end-stage renal disease, they're still not there. So I'm planning of actually going and making a presentation to the renal team here. And we haven't actually explored that area. So slowly, we'll slow and steady, making progress.
Thank you, ma'am.
Thank you, ma'am. Dr. Gregory, please go ahead. Please unmute yourself.
Yeah, thank you very much, ma'am, Dr. Fure. So I think you've answered part of the question I wanted to ask. That is for patients who have been diagnosed of chronic disease conditions, for example, those that will be diagnosed of HIV and AIDS, those that come probably take a longer time to treat. So I want to know, like, for example, the new model of providing palliative care has to be implemented almost from the time of diagnosis. So I would want to know whether it is possible for us to initiate palliative care right from the time of diagnosis of HIV and AIDS or CVA or other degenerative disease conditions. So you take up management rights from.
Yeah. So your question is whether you can initiate palliative care from the time of diagnosis in HIV/AIDS patients, correct?
Ma'am.
That's what you're asking, right?
Yes,
yeah.
ma'am.
So when HIV is being diagnosed, sorry, which country are you from, Dr. Gregory?
I'm from Sierra Leone.
Somalia?
No, Sierra Leone. Sierra Leone. West Africa.
Okay.
West Africa.
Right. Yeah. Okay. So so when these patients come to you and you're diagnosing due to some other things, you're actually doing the retropositive test. You find that they are retropositive, and then you, of course, as a physician, you would initiate their treatment like ART. You look for some opportunistic infections where they have those kind of things, and so the best way that you can involve the palliative care team is if they have pain, they have oral thrush, if they have herpes zoster, if they have any venereal disease with sorts of ulcers which are very painful, vaginal sores, those kind of things. There are a lot of things that a palliative care physician can do apart from the HIV physician, so that is a good kind of indication to involve the palliative care team because of pain. And once they are on board, they can have a regular checkup with this team. So I can't say it is wrong to sort of involve palliative care team to begin with, and the indication would be if they have pain and other things. Suppose a normal looking good performance status patient, incidentally you found the patient has HIV. I don't think at that point you need to refer to a palliative care physician. I would probably wait and say, okay, is this patient compliant with their medications? Do they have, and the other thing is what we need to remember is palliative care doesn't deal only with the patients, they deal with the relatives, the family members, and what kind of support they have. And I'm sure like HIV is a big program, isn't it? So they have the carer supports and things like that in place. But if they want to talk to someone and let their feelings out, and then a lot of guilt might be there, a lot of anger, being upset. Suppose they got the infection from their partner, and they it's not because of them that they got the infection. So there are a lot of issues and stigma in palliative care. So that is also an indication for referral to a palliative care, and not only as far as the patients are concerned, but the relatives, the wife, the spouse, who has sexual contact with them. So they should be, they can also be referred for psychological support and things like that, because an experienced palliative care team would be able to handle that. I'm sure, like, do you have a palliative care team over there, or you're the one who's leading it, or what is it?
We don't have for now. We don't have a functional palliative care unit.
Right. Okay. And you have oral morphine available?
Yes, we have.
Okay. Right. So there's no hard and fast rule, but don't make unnecessary referrals. You can always involve palliative. You could have a kind of say, okay, during their third visit or for collecting ART, they have a kind of sign up with the palliative care team and say, okay, just to check everything is normal. Their psychological aspect, the social things, their spiritual aspect. I'm sure like HIV programs are actually big and it covers a lot of these things. But somebody who is insight into palliative care can maybe contribute a bit more, make them more comfortable.
All right. Thank you very much, ma'am.
All right. Thanks, Gregory.
Thank you, ma'am. Ma'am, with your permission, shall we proceed for the case presentation next?
Please, yeah.
Sure. Dr. Sushovan, if you could unmute yourself.
Hello. Yes.
Yes, doctor, we can hear you clearly.
Hello.
You can go ahead.
Okay. Hello. I'm Dr. Shoba Nair. Today I'm going to present case
Dr. Sushovan, I think there is a
A
slight disturbance because of
45-year-old
the range. Maybe you can switch off your video. That would help with the range.
Hello.
Dr. Sushovan, you can switch
Yes.
off your video
It's
and
about a
continue.
Yes. It's some 45-year who is diagnosed with peripheral disease, but is with grade 2 wound. And his presenting complaints are pain in legs after walking for 100 approximately for the last toe, and blackish discoloration of the toe since last 3 months, and discharge of foul smelling pus from wound. The history of the present illness: he was apparently well 6 months back when he noticed bilateral leg pain after walking 100 meters. Pain was severe in intensity, cramping in nature, and was localized to both legs and foot. He got relief from pain after taking rest for a few minutes. Day by day, the intensity of pain was increasing in walking, and that has left him to abandon his workplace and restrain to home. For the last 3 months, he has noticed blackening of his right great toe and development of a wound on base of great toe, which is painful, severe in intensity, burning in nature, and remains throughout the day. The wound is emanating a foul-smelling pus. He could not sleep at night due to the nagging pain and remains anxious on how to tide over the current situation. On general examination, he was found conscious and oriented. His build was average. His temperature was 98.6 degrees Fahrenheit. Pulse was 98 per minute. All his peripheral pulses were palpable except his right dorsalis pedis, which was feeble. His respiration was 18 per minute. His blood pressure was 130 by 70 millimeters of mercury pressure. He had a blackish discoloration of a right great toe, and all his systemic examinations was within normal limits. On local examination of the wound, it was an oval ulcer over the base of great toe. It is 2 centimeter into 1.5 centimeter into 1 centimeter in dimension, punched out, reddish base with underlying bone could be seen. It is tender on palpation of base and edge, and foul smelling pus was being discharged from the wound. Now he was taking paracetamol and tramadol for pain, and betadine dressing of wound was being done by the patient himself. On investigations, routine investigations, it was found that his hemoglobin was 15 grams per DL. Total count was 9,800. His platelet counts were 1.6 lakhs per cubic millimeter, urea 28 milligram per DL, creatinine 1 milligram per DL, fasting blood sugar was 120 milligram per DL, and his lipid profile was within normal limits. USG Doppler study of bilateral lower limb showed no deep vein thrombosis. However, CT angiography of both lower limbs showed right peroneal and distal right anterior tibial artery was attenuated. Now, let's talk about the psychological aspects of the patient. It is a 45-year-old male who is working as a bank employee, as a watchman in the bank. He used to be a chronic smoker for the last 30 years, and he used to take 20 cigarettes per day. At present, only wife is taking care of him. He's anxious and spends sleepless nights thinking over the fact on how he's going to recover from his present illness and join work to sustain his family. So our main concern over here is the chronic non-healing wound on great toe, the pain, which is the claudication, as well as the ulcer pain, and his anxiety over financial issues. So in short, 45 years old man with peripheral vascular disease, Burgess disease, with painful non-healing wound on right great toe and suffering from chronic pain on walking, which has rendered him unable to attend his daily duties. So the discussion points are these. do we need to provide palliative care to this patient? Secondly, what can be done to alleviate pain for this patient? Third is, how can we address the non-healing ulcer of his great toe? And fourth, what all we can do to put him back to work and make him financially self-sustaining. Thank you.
Thank you, Dr. Sushovan. Ma'am, how would you like to proceed? Shall we put it back to the participants for discussion?
Yeah.
So our first point is, do we need to provide palliative care to this patient? Comments and opinions, anyone? You could use the chat box as well as raise your hand or unmute yourself.
So a couple of them have said yes. Yes. Yes.
So very obviously, this patient who is in pain has psychosocial issues as well. So definitely there is a role for palliative care in this scenario. So coming to the immediate issue of pain, what can be done to alleviate pain for this patient? Dr. Sushovan has already described the type of pain. He described it as a burning kind of pain, which is severe in nature. Dr. Sushovan,
Yes. Yes.
would you like to proceed with what you have in mind regarding
Yes,
about pain with this for your patient?
Yes, he has a chronic pain that is mostly vascular in origin. He has a claudication pain, and along with that, he has a ulcer over his great toe, and there is a dry gangrene of this great toe. So, being a vascular claudication, he suffers pain while walking, and he has a constant pain due to the gangrene of his great toe. So he suffers through pain all through the day, and he is spending sleepless nights because of his so much pain. So that is one of his greatest concern, that how we can tide over this situation, the pain. So I would like to ask ma'am, what can be done to alleviate pain for this patient?
Right. So I think there are a lot of answers that are being written, like surgical intervention and things like that. But with him being in the surgical ward or the plastic surgery or vascular surgeon,
Yes,
of
ma'am.
course, they would require that. A lot of people are answering this articulation, rehabilitation, etc., which is very valid. But the pain would be severe, and Dr. Sushovan had said tramadol was given. But I'm not sure what dose that he received, 53 times a day or 4 times a day.
3
and if
times
the
a
pain
day,
is
ma'am.
under control with that.
No, ma'am.
Is it a make-believe thing, or
No.
is it a real?
Pain is not much controlled. His NRS was around 6
With
out
tramadol.
of 10. Yes,
Yeah.
ma'am.
So somebody had posted, it has both, you rightly said, nociceptive and neuropathic component, because there's background pain, nociceptive, and there is neuropathic component because of the burning sensation. So
Right.
you need to take care of both. And I said I thought you said pregabalin also the patient has. Patient is on pregabalin as well.
Okay.
Isn't
Okay.
it? Isn't it? Okay.
No.
So I think opioids you can go higher, definitely. Because morphine is the drug of choice in such conditions with peripheral vascular disease. And of course, that's not a permanent solution. You have to go in with vascular surgeons and see what they say. Sometimes they give, to buy time, sometimes they give prostaglandin infusion just to dilate the vessels, so that there's some amount of blood flow. And morphine, definitely you need to give this patient either orally or injectables, and put him on a good dose of pregabalin. Start on pregabalin 75 milligram HS, and make it BD within 2-3 days. Make it twice a day, and then go up on this. And if the patient is not able to sleep, it's a good thing to add clonazepam. And please remember that clonazepam, even though it is categorized as benzodiazepine, it is used for pain relief. Okay, can be used for pain relief, for anxiety and for sleep. It's a very good drug to have. So I wouldn't hesitate to add a 0.25 milligram HS for this patient of clonazepam and pregabalin to begin with HS for the pain,
Okay,
and
ma'am.
then
Thank
BD dose from then on, and a good dose of morphine 5 milligrams or maybe Q4H or injectables 1.5 or 2 milligrams every 4th hour. Anything else? Anybody has any other idea? Do you have experience with using Nefopam? Anyone? Nefopam?
No responses yet, ma'am.
No responses yet. So I think probably people are not familiar with Nefopam. I think a lot of anesthetists they use Nefopam. We use Nefopam left, right, and center here. We made it available in our pharmacy because it's a very good drug to have in your armory. Nefopam is a centrally acting non-opioid, non-NSAID medicine. Okay. Somebody is asking, so I'm taking a detour here. Neelam is asking whether pregabalin or gabapentin is better. Pregabalin is definitely, supposedly better because it is the latest find, and there are a lot of literature on it. But some people they kind of do better with gabapentin, okay, because pregabalin can also have a lot of side effects. So now coming back to Nefopam, if you can't give paracetamol, if you can't give other medications like NSAIDs, it is our go-to drug, and sometimes we give it as an add-on with morphine, paracetamol, and NSAID. We give Nefopam. Nefopam, the way that it acts, we need to remember is it has a lot of different ways of acting. It acts on the descending inhibitory pathway where you increase the norepinephrine and serotonin, and it also acts on the NMDA receptor. So it is very good for neuropathic pain, and it is available in IV preparations available. So the dose of Nefopam is 20 milligrams IV 3 times a day to begin with, and the IV dose of Nefopam, the maximum is 120 milligrams. The oral dose of Nefopam is available as 30 milligram tablets. You give it 3 times a day, the maximum dose of 300 milligrams. It is not a must. If you don't have that medication, don't worry. But if this patient is under us, we would probably give injectable Nefopam. The price is not too much, Dr. Newstar. I think it's as expensive as tramadol is what I'm made to understand. It's like kind of 8 rupees to 10 rupees. I'm not sure about the injectable, but the tablet. So it is a very affordable drug, and it's a good drug to have in your armory. Okay. And the other drug that can be used for such patients is clonidine. Clonidine, which is an alpha-2 receptor agonist, which acts on the postsynaptic pathway. Okay, postsynaptic pain transmission pathway. It's a very good drug. Only problem with that is it is an antihypertensive, so you need to be careful that the patient is not going to stand up and have a postural hypotension and fall down. The normal dose is 0.1 milligram, which means 100 micrograms. You start at night because the patient is sleeping, and you can increase it up to 3 times a day. It is also a good drug to have for de-addiction, in the sense the withdrawal symptoms of opioids. Well, that's another discussion altogether. That's a different topic altogether. But these are certain drugs that you can use in these patients. But the common drugs that we have in most parts of India is morphine, pregabalin, paracetamol, clonazepam for this patient, definitely. Combination of gabapentin and nortriptyline. Somebody has asked a question. So there are a lot of combinations with pregabalin, nortriptyline, gabapentin, nortriptyline. It's a difficult choice, Dr. Neelam. You can take your call. I can't say one is above the other. But off late, our practice is to prescribe pregabalin. So maybe my tendency would be to go along with pregabalin and nortriptyline, I would say. Okay, the next question is, how can we address the non-healing ulcer of this grade? I think a lot of people have answered this, refer to surgery, vascular surgery, plastic surgery, and do what is required. Okay, what all we can do to put him back to work and make him financially self-sustaining. I think definitely social workers need to be put in act here. They need to contact the bank itself, might be providing him with all sorts of treatment options. And I think if he's working in a bank, he might have some financial help from the bank, but I'm sure like he can't take forever leave, depending on which category, whether he's a permanent employee or not. So somebody needs to find out what that is. And there are a lot of programs which is available, Pradhan Mantri Awas Yojana, I don't know what that is. But there are a lot of NGOs that can be contacted, and I'm sure a good social worker will have the contact of all these people to help and support him financially. I think that can be looked into. Are there other questions?
Ma'am, there's a specific question on, because we have spoken about claudication in this patient, will pentoxifylline help in this case? Do we use this in palliative care settings, ma'am?
No, we don't prescribe per se pentoxifylline, but we do find the vascular surgeons prescribing it. So they are already on these kind of medications. So we don't, because we work in a multi-specialty hospital, all these other paraphernal is already there. And they involve us because the pain is not under control. So we don't prescribe pentoxifylline per se because they're not directly admitted under us. I've never prescribed on my own, started on my own pentoxifylline.
Thank you, ma'am. If there are other questions, please feel free to use the chat box or unmute yourself. We still have a couple of minutes to go. Meanwhile, just highlighting the importance of palliative care in non-cancer settings. So during my time in Manipal in Karnataka, we had done a study. It was a community-based study amongst 2,041 people, out of which for nearly 4 to 5% of them required palliative care. As ma'am had mentioned, there is something called a SPICT tool. It's a tool. It's a supportive palliative care indicator tool. Which can indicate which are the kind of patients who require palliative care. So out of the 88 people who required palliative care, amongst those 2,000 odd participants, there were only 2 who had cancer. Remaining 86 of them had non-cancer illnesses, out of which a majority of them had cardiac illnesses followed by dementia and frailty, which is old age. So this study actually highlighted what ma'am was trying to say, that the role of palliative care in non-cancer illnesses is huge and waiting to be tapped in. A lot of contribution needs to happen from the palliative care family as such, which includes the physicians, physiotherapists, social workers, and of course a huge volunteer base. Like the last question, which was there in Dr. Sushovan's discussion point, to vocationally rehabilitate a patient, a huge role is played by volunteers or neighborhood volunteer networks, which is a core part of palliative care.
So I've mailed the SPIC tool to Priya at tipsecho@palliamindia.org. Priya, so you can distribute it to everyone. Thank you.
Okay.
Right, ma'am. I think there are no more questions which is coming in, no more hands raised. So
Right,
probably
okay.
we can call it a day. Thank you so much, ma'am. Any
Much.
closing comments from your end, ma'am?
Not really. It's like, when you see non-malignant patients, and cancer patients, we need to sort of look at the kind of suffering that they go through. And a lot of people, they don't realize that these kind of patients with COPD, cardiac failure, etc., they have so much of symptom burden. So if you come across people asking you, you have this, what else can I do? Your relatives, your friends, your family, distant relatives, etc., please do jump in and say, yes, as palliative care people, we can help. Please do refer them to us, that sort of thing, or go and see them and, assess them properly and, make a proper medical assessment and see what can be done. So there are a lot of things that we can do. So don't hesitate to, take a decision and jump into this is what I want to say. All right.
Thank you so much, Dr. Shoba Nair, for joining us because we all know that this is towards the end of the day and you might have had a very busy day and still you found out time for this cohort. Thank you so much for your time. And thank you everyone for making this session very interactive. And before winding up, just a couple of points that we have already released the second